Here in Madison, it's a significant problem, and it's increasing at an alarming rate.
They're taking them from grandpa and grandma's house, out of a medicine chest, taking them from parents who are not using them. People are doctor shopping. They're getting multiple prescriptions filled through different prescribers.
75% of current heroin users began with prescription opioids, so about 3/4 start with prescription drugs, their own or someone else's.
My addiction got to the point where I couldn't function day to day. I couldn't show up to work.
You wonder, are they treating the stress or anxiety, or are they treating the pain, or both? And sometimes it's very difficult to dissect the two.
Today we're kicking off a week of activities featuring Don Teater from the National Safety Council.
There's a lot of evidence for the fact that, medicines or therapies other than opioids are more effective pain relievers. So I think both clinicians and patients need to be educated about what actually alleviates pain, what are some of the societal and personal impacts that can arise from opioids that maybe we just don't even need to deal with if we find less powerful but equally effective ways of dealing with pain.
Hi, I'm Dr. Don Teater, Medical Advisor with the National Safety Council. We are in Dane County, Wisconsin this week, documenting the efforts being done here to prevent prescription drug overdoses. With me today is Dr. John Ewing, an addictionologist with New Start. Dr. Ewing, we're here to talk about us, about our role as the prescribers, both in the treatment of pain as well as in the treatment of some of the side effects of the medications we use. You are an addictionologist. Can you explain to me why do you think we're having this problem in Dane County and throughout our country with the use of opioid medications?
I think we've been misled about the nature of opiates. Opiates imitate endorphins, and endorphins are an important part of our stress modulation pathway. So basically, opiates dampen our response to stress. A side effect of this may be some pain reduction. The consequences, though, of giving somebody an opiate is that they adapt rapidly and then they become more vulnerable to a rebound stress response. And part of that rebound stress response is increased pain perception. People that have anxiety, depression, people that are vulnerable to stress are particularly vulnerable to want to use opiates and other substances to cope with life. And so, unfortunately, a minor injury, a tooth extraction, followed by a prescription for pain medications can lead to a life of searching for opiates and for relief that is essentially caused by the medication.
Why do you think it is that physicians are prescribing so many more then?
I think that the public perception that opiates are going to eliminate pain is not correct, and that we have not corrected that. Instead, what has happened is a lot of information from drug companies has come out to the effect that these medications will miraculously relieve your pain 100%, and a lot of patient advocates have given the message that if you're still having pain, you should ask for more medication. In truth, the opiates dampen pain by 20, 30%, sometimes 50%, but they really don't relieve pain. Mostly they relieve the patient's sense of stress.
Right, so it may be that our patients with the more stress, those that have pre-existing mental illness or depression or anxiety issues may be more susceptible to having problems with these, is what you're saying.
That's true, and unfortunately, a lot of prescribers are susceptible to the patient's mood. The biggest thing that we see, the common feature that makes a patient most likely to get a prescription for opiate pain medications is actually not their pain or their level of function. The most common thing we see is actually depression. The patient comes in with depression and pain complaints. These are the patients that are most likely to be prescribed opiates.
All right, and then when those with depression take an opioid medication, their depression seems to get better, or they have a positive response. What is it that happens then?
Basically, the stress system is temporarily dampened by the opiate, but then there's a rebound stress response. There's an end of dose failure, and then an amplification of the pause and recover fatigue that is the other side of taking a pain medication or having a big burst of endorphins.
So why do you think it is physicians don't understand this aspect of pain medications and their properties?
I think that there's been a lot of marketing out there on behalf of some drug companies and patient advocates to think that to cause physicians to think that the responsible thing to do is to prescribe a pain medication like an opiate. But in fact, we are better off addressing the pain generator and improving the patient's function. And so the miraculous properties of opiates that some of these advertising efforts have instilled in physicians is just not correct.
Right. So you had mentioned earlier, and I'd like to get back to this, the point that you made that opioids are really not very strong pain medications.
That is correct. They dampen our response to stress, and a side effect of that dampened stress response is sometimes a decreased perception of pain.
You're a family physician by training. How should physicians handle this then when patients come in with, acute back pain or an injury of some type? How do you think they should be treating this pain?
I think that physicians should bear in mind that just like with the steroids, like cortisol and prednisone, we may be temporarily dampening an inflammatory response or a stress response, and just in the same way with opiates, we may be dampening the stress response to discomfort, but at the same time, there can be a rebound inflammation, rebound effect, and we've learned that pro-opiomelanocortin is actually the source molecule for both ACTH and for endorphins. It's the same system, the same pathway. So we don't like getting our patients strung out on steroids because we know the consequences of that. We should be equally suspicious about getting our patients dependent on opiates.
So do you think opioids have any role in treatment of pain in family practice?
I think that when a patient is in such distress and discomfort that they are writhing and we are unable to examine them and they are unable to cooperate with the therapeutic process, that sometimes an opiate may be temporarily beneficial.
To treat some of that emotional distress that they seem to be having at that time?
Yes.
What particular challenges do you think physicians face when approaching these patients as far as use of opioids or other non-opioid medications?
I think patient education takes time, and we're driven to have good patient satisfaction scores. And if we educate our patients about the consequences of dysregulated stress response and how they will feel at the end of a dose when they've become dependent on opiates, if we take the time to do that, most patients will be hesitant to use opiates. We also need to educate patients about disposing of any opiates that they have to help decrease the chances that some bystander, one of their children or cousins, will get the medication out of their medicine cabinet and develop an addiction.
In the past 20 years, we've really seen a huge escalation in the prescription of opioids, increase of 600% at least. Most people now agree that we are prescribing too much. You seem to think that we're prescribing way too much, and I will share with you that I agree with that. Should we go back to the levels we were at 20 years ago when we were hardly ever prescribing these medications?
I think we should go close to that. What happens is that when we give somebody opiates, their pain sensitivity actually increases. They become then dependent on the opiate to have normal pain sensitivity. Well, fortunately, when we prescribe less, then their pain sensitivity also can migrate downwards, and we can end up having patients that are no longer on pain medications and that feel less stress and that have an increased joy in life. In the past, part of my practice was to slowly taper people off of their pain medications. And most people were thankful after the process was completed and expressed increased joy, energy, and decreased feelings of overall stress.
Yeah, and I will share, I'm aware of several studies that have confirmed that very point, that people that are on chronic opioids, when they're weaned off, the majority of people do feel better. Their life has a higher quality.
Yeah. In fact, because opiates imitate endorphins, and endorphins are part of our stress response, when people are on high-dose opiates, what we're doing is actually we're instilling a state of chronic stress.
Can you give me 3 takeaway points, points that you would like to make in particular regarding this issue of opioid overuse?
Hesitate long and hard before you prescribe opiates for more than a few days. Use the lowest effective dose. Counsel your patients to dispose of any leftover medications. Counsel your patients not to mix them with sleeping pills, benzodiazepines, or alcohol. And then counsel your patients that these are pain reducers or stress reducers, not so much pain relievers. That is a myth that opiates are pain relievers. And also counsel them about the discomfort of rebound pain and rebound anxiety and stress that can result from using opiates for more than about a week.
Very good. Dr. Ewing, I thank you for your time today. This is Dr. Don Teater with the National Safety Council from Madison, Wisconsin. Thank you.